Thank you. It's indeed my pleasure to be here. Pope, I'm surprised that there are so many of you here today. So my talk today really is focused on, it's focused on some of these big picture items in the context of getting to zero, ending the AIDS epidemic, that general theme, and how you get there. And one of the key issues in how you get there is achieving a very high level of viral suppression among those in care. And as it turns out, there are a lot of policy issues. Bob pointed out my career. I spent 20 years in public policy, working for Governor Brown in California in his first term, then for the California legislature, and then 11 years with the US Congress. So that was half of my career, and then 20 years in academics. So I've got a very interesting mixed career that in some ways has, particularly the public policy years, left me very curious about the use of evidence in making policy. And in particular, when working for the Congress, it was always frustrating that we didn't have empirical evidence for a lot of the decisions we were being asked to make. And so when I went back to UCSF, I founded this AIDS Policy Research Center to try to develop mechanisms for timely data collection that would inform public policy. And in that tradition is what I want to talk a bit about today. So there are basically 4 themes in the talk today and 4 take-home points. The first of them is that, first of all, states are primarily responsible for implementing the National HIV/AIDS Strategy and the Continuum of Care Initiative, which have come from the White House. But states are figuring out exactly how to do it, so that a lot of this talk is about what states are thinking. And each of the states that I'm going to talk about have developed resource-intensive interventions so that they can meet some of these national goals, particularly around virologic suppression. The second general theme I want to talk about is the importance of policy environments and how to measure them and how to think about them and how they can be used to monitor and evaluate progress towards achieving goals such as the New York State ends the AIDS epidemic. The third point I want to talk about is not just adherence, but the steps that are necessary to achieve 90% viral suppression, one of which is adherence. And some of the things we don't know that researchers could be very helpful in developing empirical evidence to move that agenda along. And then the last general theme is one that I think most interventionists are aware of. It's the importance of timely feedback to clinics and to people who are implementing programs, and how important that is to achieve your goals, whether it's a clinical trial or, in this case, the delivery of services, and how states are going about implementing their state plans. So that's the general outline. So I wanted to first give a little bit of background about these goals. And I wanted to talk a bit, I think you're all familiar with the UN AIDS 90-90-90 initiative. And while it was formulated primarily in a global context, it's actually a very useful framework for the United States as well, and has been, unfortunately, hasn't been used as much in shaping our policy directions as it might be. But the general concept is that the goal is to get 90% of people aware of their HIV status, and of those, 90% receiving sustained ARV therapy, and of those, 90% virally suppressed. And according to the modelers, if you achieve this 90-90-90 objective and meet the targets, by 2020, it would enable us to end the AIDS epidemic as we know it by 2030. So this is classic prevention, isn't it? Right? Yeah, ending the epidemic. So I looked up some stats for New York. Dennis Nash is not here, but his group at Hunter has just put out this dashboard. It's wonderful. If you don't know the dashboard, look it up. Apparently, based on their most recent data, which is not up to date as we know it, it's because they measure at the end of years, and they're looking at the end of 2013. But New York State had 87%, which is very close to 90, of people aware of their HIV status. So doing very good. And 77% receiving some form of care. Unfortunately, current surveillance systems do not measure sustained ARV therapy as a key indicator, which would be very helpful as a new indicator to add to what's already being collected. And most importantly, New York State has 82% of those in care virally suppressed. So that's how you're doing. And I'll talk a little bit more about how this measurement is made. But first, the 90-90-90 initiative and some of these goals that have been set out in the New York plan and others are important because targets drive progress. They promote accountability in a measurement way. Those of us with a background in monitoring and evaluation are really big on these things. New targets are needed for action by 2015, and you know the White House in July released a revised national HIV/AIDS strategy with new targets for 2020, replacing those they had in place for 2015. And bold new targets underscore the importance of this general theme of ending the epidemic or getting to zero. So a little technical note on how you measure viral suppression and the goal. The current goal for the United States is to increase to 80% by the end of this year the percentage of people diagnosed, this is adults, in care whose most recent viral load test showed that HIV viral load was suppressed. And so in order to do this, you have to have a numerator and a denominator. So the numerator is the number of HIV diagnosed adults in care whose most recent viral load test, it has within 12 months, showed that the viral load was suppressed. So that's the number on top. The number on the bottom is the number of adults with HIV infection diagnosed by the end of the previous year and alive at the end of the year, with a documentation of at least one CD4 or viral load test during the year. Now, this one test during the year is a fairly minimum standard, so if you actually measure it, as some states do, with 2 or more visits, you get a much higher level of viral suppression. So that's the technical part of how you're measuring it, and the goal of 80% was set by the CDC, Division of AIDS Prevention. And at baseline in the United States, they calculated that the viral load suppression rate was 71.6. 2009 was the baseline year, and at baseline, New York was at 70%. and now they're at 82% at the end of 2013. So there's been rapid progress on this metric in New York State, now exceeding 2 years early the national goal. The 2015 goal reflects a 10% overall increase from baseline. So that's how how CDC came up with the number. Problem. The viral suppression rates are reported for states, only for states with complete laboratory data, which CDC defines as at least 95% of laboratory results are reported to the surveillance program. So what that means is that we have been able to measure at a national level, we're working with data from 18 states, and we're excluding 32 states, which makes it very problematic to measure progress towards the national goal. And why is that? Well, let's first of all look here at these are where you'll find. Let me see. Here's New York, and you see there's 70.2 at baseline, so that's pretty good. California was pretty good. It was up here, and North Dakota at 81.3%. I looked it up. There are 185 people living with HIV in North Dakota, so if you wonder. That compares with 132,000 in New York. So anyhow, that's how they're calculating it. So backing up a bit, if you understand our Constitution, and this is a battle between Democrats and Republicans that you will see played out over and over again. The Republican philosophy is that the role of the federal government is national defense, and just about everything else is done by states. The Democratic position is that there are certain initiatives that we should be thinking more broadly, and that there is a role for education and environmental protection, and on, and public health. But right now, public health activities are run by each state, and the CDC doesn't control the states. They can recommend, they can come up with best practices, they can come up with carrots and sticks and give more money if you do it the way you want to do it, but all that. But the states themselves, each one of them has to figure out how they're going to accomplish these goals on their own. So it's in Congress, again and again, members will refer to states as laboratories of innovation. So you have 50 states doing things differently, and some are doing better than others. So these are thought of almost like demonstration sites, the 50 states. And for those of you with a research mind, you can learn a lot from demonstration sites, and you can learn a lot from the differences across states and how they're approaching this complex problem solving. So now I want to talk about a specific research project. But first I have to explain. I know our folks from the AETC know HRSA well. And many of you may work with HRSA, but I think more frequently people here work with NIH. HRSA is quite different, but their research arm is called Special Projects of National Significance. And what they do is largely demonstration projects. So they will find 15 sites across the country who will competitively bid to be in it. They'll try to get them to do something like interventions for prevention with positives, and they'll have an evaluation center which will evaluate the 15 sites, and they'll come up with metrics around efficacy, utilization rates, cost, and how it relates to various outcomes. And when they have the best practices from these demonstration projects, they then try to replicate these in other sites. And from their prevention positive, for example, from that initiative, which I was heavily involved in, what you find in the medical monitoring project is that the Ryan White clinics actually have implemented a lot of these interventions in their clinical sites, and when you and much more so than when you compare them to non-Ryan White facilities. So it's been a very important project in improving the quality and moving from evidence to best practice among the Ryan White Care Act. And the Ryan White Care Act, I forget the exact number, it's over 60%, I think, of people receive care through Ryan White care facilities, so it's important. Tragically, the United States Senate, in their appropriations bill, has decided to eliminate this project, defund it. So there's considerable concern that this needs to be corrected before there's a final budget for the year. I can talk more about the politics of that later. In particular, today I wanted to talk about one of the projects called Systems Linkage and Access to Care, which rather than demonstration projects in clinics around the country, it's a demonstration project with 6 states. So you work with the states. And they were asked to develop and evaluate innovative models for linkage to and retention in HIV care. So, a little bit about that project. So this initiative, which started in September of 2011 and will end in next August, is in 6 states: Louisiana, Massachusetts, North Carolina, New York, one of the states, Virginia, and Wisconsin. And so they receive $1 million a year from HRSA, and then to develop and implement these initiatives. And UCSF has the contract to provide technical assistance and do the evaluation across the 6 states. So that's the design. The first 2 years were based on learning, so a learning model where they convened stakeholders to review what was the evidence on best approaches to linkage retention and viral suppression, as well as detection. And from those consensus meetings, they developed a set of interventions in each of the 6 states, which they've now implemented, and we will evaluate at the end of next year. So I'm not going to talk about the outcomes here. The goal of this talk is not to talk about what the 6 states are doing or how they're doing. Some of them have already reported significant effectiveness in some of these interventions, but that's not the purpose of my talk today. Rather, we have taken the opportunity to discuss more particularly what the states are doing more broadly to address the continuum of care goals, some of which are outside of the particular SPINS initiative funding, if you get what I mean. So we undertook key informant interviews, which are like qualitative interviews, except you find people who are reporting from their capacity as administrators of programs. And 2 of the questions that HRSA raised for this larger initiative is: what are the structural and policy characteristics that facilitate or hinder implementation of interventions? particularly those that are out. We were interested in the viral suppression piece of this, but that was the question as framed by HRSA. And what characteristics of interventions lead to increases in successful viral suppression? So we asked, we conducted these interviews. Each of the 6 state health departments agreed to 1-hour key informant interviews where they talked about how they were planning and thinking about how they would reach these goals that had been established at a national level. The goal of the interviews was to better understand each state health department and their thinking about, particularly, we focus on achieving 90% viral suppression because that, in most of these models, that's the end goal. The detection, the linkage, the retention all lead to a goal of viral suppression. And with viral suppression at that level, you should have reduced onward transmission. So it's ultimately not only a continuum of care, it's a continuum of prevention as well. So the first set of findings have to do with what we're calling state policy environments and why they're important. So some of this work we've done in international settings, but we haven't done much in domestic settings. So this was an interesting project to see what are the characteristics. And what we found were 10 policy facilitators. Now, you may think New York. When we turn this into a scale, there are 10 items. Each gets 10 points, and you can assign a 1 to 10 for each of these characteristics for your state, and you can reach consensus in group meetings, and then you can do it on an annual basis to check as a monitoring progress, as I know people are interested in monitoring progress on a number of things. So you can either evaluate where you stand relative to the other 50 states, or you can use these to monitor progress for yourself in an individual state. At any rate, the first characteristic or facilitator was support from the executive branch. So in New York, this would be things like Governor Cuomo's embracing this planning process for ending the epidemic, which was initiated by activists but embraced by the governor's office. The second is dedicated HIV funding from the legislature. So the legislatures and states provide the funding, and then the executive branch administers the programs. So there's a wide range in the 6 states that we looked at, from no funding at all from the state legislature to over 1/3 of the funding coming from the state and the rest from the federal government through the various Ryan White and CDC and other programs. The third characteristic or facilitator was advisory groups beyond the federal requirements. There's required planning for Ryan White and for CDC prevention. Many states have combined those in more recent years. But other states have these additional groups, like Massachusetts has a consumer advisory group that meets 4 times a year, and the consumers have direct contact with the program administrators and tell them how they're doing and what it's like for them. So these are planning processes that are beyond those required by the federal government. The next is a timely state plan, and many of the state plans they vary greatly in the 6 states we looked at, from 1-year plans to 5-year plans. Some had very specific monitor and evaluation metrics. Some just had global discussions of what was going on in the state and what they'd like to improve. But the ones that had the most clearly developed objectives were facilitating progress, because you could measure progress in that context. The 5th characteristic was a research capacity. Some states have considerable research capacity. As you know, New York is fairly unique with the AIDS Institute. Other states have strong partnerships, like the ones between the University of North Carolina and the North Carolina Department of Public Health, or LSU and the Louisiana Public Health. The point being that the one way or another, the state has an ability to conduct research, or in particular, look at data that would inform policy or directions. The 6th is the states regulate health insurance plans. All of the states have exchanges, whether they run them themselves or they're run by the federal government, but some states get into specific policies, such as prohibiting tiered pricing for HIV drugs. Others don't. So you have a real difference in terms of the quality of the plans that are offered in each of the states. The 7th is Medicaid expansion, and as you know, some states have followed through with Medicaid expansion, and I know the transition issues that many of the AETCs are looking at are heavily related to Medicaid, and particularly Medicaid managed care and how that all works out. Others have not. The 8th is Medicaid programs that have HIV specialty care. So, for example, Wisconsin has a program where people with HIV are eligible for a medical home, an HIV specialty care medical home. They're the only one of the 50 states that has such a specific program. The 9th is surveillance data is used for linkage and retention. And this is the whole communication between the surveillance branch and clinicians and providers. That has evolved more recently as people have become more and more concerned about linkage and retention. And the way it's done varies extensively across the states. So you can determine whether New York is really good at this or not so good at this, and that becomes part of your evaluation of New York. And the last, I'll talk a lot about later, but the best facilitating policy is timely, such as quarterly feedback to providers and clinics, and ultimately feedback in real time is what we're looking for, so that people have a corrective feedback loop. So again, this can be used a number of different ways, but these were the 10 facilitators in state policy that turned out to be most important. Are there any questions on this part before we move on? All right, we can move on then. So this is a map of Medicaid expansion sites, and what you can tell from, what do you see in this map? Kaiser did not make it blue and red, but they might as well have made it blue and red, and it does look more or less like the Electoral College, but what you see is that this this is a proxy for whether their Medicaid expansion is a proxy for how challenging it will be to achieve these national goals. And you'll see that the problem in achieving these national goals is going to be much more significant in the southern states than it's going to be in the rest of the country. And they start with more disparities in outcomes by state to start with, and because of the Roberts decision that this was up to the states, it has left a pattern like this. And in particular, just so you have this in mind, just 5 states account for half of the AIDS cases in the country. So New York has 15%. California has 12.8%. Florida is going to be a problem. They're at almost 11%. And Texas is at 7.4%. And Illinois is at 3.7%. So those 5 states are important. So the problem states in particular are going to be Texas and Florida. You'll see this evolve. It's clear that this is going to be a problem. Interesting, Alaska just decided to expand, and Utah's working on it. Florida defeated it soundly, even though it looked like it passed the House and then the Senate, and then it was defeated 2-1 in the House. Okay. The next part of my talk is about the kinds of interventions that the states are developing to respond to the need to link, retain, and have people virally suppressed. So here are the statistics. Remember, the national goal is 80%. So half of our states are 2 years early in achieving greater than 80%. Wisconsin.
90% or 80%?
Right now, the national goal is 80%. We're saying the national goal should be 90%. And in fact, in our interviews, the health departments largely agreed with us that 90% was achievable and would be a better metric. Unfortunately, even the revised national AIDS strategy from the U.S. in July kept this 80 as opposed to 90. So there's still a dispute about this. But you'll see the northern states doing well, and you'll see that the southern states are falling behind. Yeah?
I just ask a quick question. Are they all defining viral suppression the same way?
Yes.
Which is?
Well, if you go back to my first slide, oh, you're talking about, yes, they're using the CDC definition. If you're talking about just calculating suppressed, not suppressed, they use the CDC definition.
So it's among those in care?
Among those in care. So you'll see that there's considerable range, and as you get into the policies in each of these 6 states, a lot of this makes sense. Yeah.
The states differ also in terms of the percentages of people who know that they're positive.
They do.
In a way that is not a part of these figures here.
Correct. You could do this for, as I mentioned earlier, the proportion aware of their HIV status in New York, and you can do that for each of the states. And we don't have a great metric for sustained ARV therapy, but we do have this metric of at least one care marker in the prior 12 months calendar year. So we have metrics that are fairly good. Some could get better, but
then the discrepancies probably would even be stronger, bigger, if you would take that into
oh yes,
knowing one's status.
yes. For example, If you add people who are not in care, New York's 82% falls to 66%. So this is all, we're parsing some of these as you want to increase each of these steps, of course, in the cascade, but right in this particular discussion, we focused on one in order to get some clarity about how people intend to get there. So here's a quote.
So this is really the most optimistic because you're already taking.
So these are people in care.
Who got into care.
Right. So they have at least one care marker. So here's a quote which reflects some of the thinking among the administrators in the state, the planners, and they talk about the last 10% challenge. And this is, what happens now is that most of our clinics are able to achieve suppression rates that go up into the high 80s, low 90s, with some outliers. And increasingly the problem is dealing with these patients that are so challenging to address in terms of their social needs. But increasingly that's got to be where the attention is going to have to be focused. So this is the general theme that's emerged across all 6 states, is that you can get to a certain level with management and reminder phone calls and but at some point there's a group that is very hard because of social needs that needs to be addressed. So in terms of what the states are doing, each of the 6 states is testing resource-intensive interventions, which go beyond traditional case management. And the characteristics are that they have a lower caseload, they work with people outside of the office as opposed to in an office, and they work for longer periods of time, as over a year, working intensely with people. And these are called different things in different states. In the literature, a lot of it is called patient navigation, but they call them linkage to care specialists, bridge counselor, a lot of different names. Each state has a different name. The other thing that emerged from all these interviews is that the health departments are increasingly using disease investigation specialists, or DIS officers. Do you all know who the DIS officers? These are the people who go track down people with syphilis and gonorrhea and stuff and get them into the clinic and make sure they get treated. But what they found is that these people are good at finding people. But their training is not particularly good at counseling people. Or they aren't particularly knowledgeable about care settings or insurance plans or ADAP or any of that. So they've had to retrain these people in the states that are using the DIS officers. But, all right, did I? Yeah, sorry. This is a quote about the disease investigation specialists, why they're using them. But we realized for people that clinics couldn't get into care, we really needed people with DIS field work experience. I mean, just because you call a case manager and you're now called a whatever, interventionist, doesn't mean that they are very comfortable in the field, you know, dodging pit bulls and drug dealers. Like that quote. You can guess which state that was. Yeah. Anyhow, back to Ryan White. Ryan White is a remarkably flexible program, and medical case management includes the definition. It's a core medical service under Ryan White, and it includes the provision of treatment and adherence counseling to ensure readiness for and adherence to treatment. So in these case management plans, there has to be an initial needs assessment. You have to develop a comprehensive, individualized plan. There has to be coordination of services. Clients are monitored for progress and their periodic evaluation. So it's pretty systematic what's done under medical case management. And what you're really talking about, these interventions that have been developed are a really enhanced form of medical case management. The problem, if you call it patient navigation, which it's often called, and that's particularly from the cancer literature, which has been used in a lot of descriptions in the HIV literature as well. It also is the same term that appears in the Affordable Care Act. And for example, the House Appropriations bill for Labor-HHS prohibits any funds any funds to be used for patient navigation, because they're trying to go after the Obamacare, right? So the less you call it patient navigation and the more you call it enhanced medical case management consistent with the Ryan White language, the more success you're likely have to be able to pay for it. So the next part of the talk is really about adherence and what's going on in terms of the cascade here. So if you really break it down, there's actually a little mini cascade within the cascade. And that the first step for people who are in care is the provider has to actually prescribe ARVs, right? And there's slippage there. That's not 100%. Not everybody who's detected with HIV is prescribed ARVs. In the Getting to Zero initiative in San Francisco, the goal, someone is assigned, when someone is diagnosed with HIV, to get them to take their first pill within 24 hours. And that means they have to figure out how it's going to be paid for. And so they've come up with this emergency ADAP. ADAP does not require documentation for the first month of coverage. And our state office that does this is staying open till 8 o'clock at night to handle these emergency ADAP applications. When you think of that intense effort to get people started, it is quite different than, oh, well, we'll write a prescription and maybe they'll go to the pharmacy and maybe they won't. So it's both getting the providers to prescribe, which interventions like clinic procedures or electronic medical records with prompts, those sort of things would all work. Some QA measures, I know New York is doing those, and some provider education could be useful for that, the slippage that you have at that level. The second step is that the patient actually has to agree to take the medication, and some don't want it. So this is generally thought about as readiness counseling, but in fact, much of what you find are that these are kind of social work issues, and that often related to housing and other mental health, substance abuse, obviously. So it's really needs a intensive intervention before people are really ready to take the meds. And so that goes back to what the states are doing in terms of these intensive interventions that they've developed. The next step is that you have to figure out how to pay for the medications, which theoretically, if people are uninsured or underinsured, ADAP should be able to cover. But a lot of people have gone into really bad plans through the exchanges So they have very high deductibles and co-payments, and they just say they can't afford the meds. So a lot of these issues need to be worked out. So in some part of the intensive work that needs to be done, we need better models for benefits counseling and for how to get people on meds as quickly as possible with minimum or no co-payments and deductibles. So if you think about it from a health insurance point of view, you want to get revenue, right, for everybody. So co-payments are important. Deductibles are important. They help run. But if you think of it from a public health perspective, if you're trying to get people's viral load suppressed so there's not onward transmission, it makes more sense to pay people to take the pills than it does to find ways to charge them money that they may not have to get the pills. So we have a cluster of issues that are unresolved in this area. And then once all that's done, they actually have to pick up the pills. And right now, there's very little tracking about this. There's very little connection between pharmacy and pharmacy benefit management and the clinicians. Those of you old enough to be on Medicare, you get, each month you get a list of all the medications you've picked up in the last month. But the providers don't get these lists. So it's quite possible. And this involves interventions with pharmacists and pharmacy management that are linked back to the overall goal.
So the single payer system would take care of this? If you
Single
had a
payer,
single
yeah.
payer, Bernie Sanders, single payer, as many of the European countries would
Right.
take care of it.
Yes, the Medicare for All,
Yeah,
which is basically the Sanders approach, would take care of it.
right.
Yeah. Mhm. Okay. And then you get to adherence, which is very important. And we do have various ways in which this adherence counseling can be done. So prescribing, this is a quote from a clinician, and we have patients who come in and say they don't want meds, and you think, they're not going to be ready. There's just no point. It's more important to make sure they feel heard. Okay. So there are different points of view on adherence. One is that adherence is less important because you don't have to take 20 pills a day. What did I do? Okay. It's less of a problem when people were taking all these pills now. But as you know, medications have gotten easier and easier, and adherence is easier and easier. The other point of view that came out of the interviews is it's more of a problem. And in this state, they were writing an RFP for adherence counseling. We will be incorporating things like motivational interviewing, harm reduction, and working with most non-adherent. And we've shown through a project here that this type of program was able to reach over 90% viral suppression rate for that population. So in this state, they are actually, one of the universities did this project, and they're using that. And they had stopped this program because they had an ADAP waiting list, and they had to move all the money to the ADAP waiting list, and they stopped doing this. Now they're with some savings from the exchanges. They were, although they weren't a Medicaid expansion state, they were able to start this new program on adherence. Okay, lastly, I wanted to talk about timely feedback and what we call the data velocity challenge. There's what I would call a data velocity issue. If there can be some way to really deal with this as an informatics problem to help increase data velocity, the main idea is that we're going to try to get more timely, more relevant, and more locally relevant information into people's hands so that it can be acted upon readily. So there's no question that timely feedback to providers is motivational. We've seen that. That's what we do in clinical trials. We give feedback and brainstorm how you can get more people enrolled, that sort of thing. Secure messaging of out-of-care lists. They're called line lists to providers, and bidirectional communication between the providers and the surveillance system are really quite important. And the other thing are report cards, which New York does as part of its quality improvement, has done for years, but is one of the few states to do it. And dashboards, where you get feedback. So if your clinic gets to see on the dashboard what proportion of the patients in the clinic are virally suppressed, and then it can be broken down by provider. So this gives feedback that is motivational to work through some of these problems. So, and it also helps with technical assistance. So here's a quote on timely feedback. So we look at the facilities' viral load suppression rates across all the facilities that we work with, and then we divide them into quartiles. And we have a number of interventions for the low performers, asking them to send a plan that addresses viral load suppression, and then we provide enhanced TA to those facilities. So you can see that this is a timely feedback to the providers and an action plan to try to improve the quality. So, policy implications. In the state health departments implementing the national goals, mechanisms are needed to build research data analysis capacity. Some states have no ability to do this. Other states have considerable ability to do this. But mechanisms need to be developed either internally or through partnerships with universities that have the capacity. States, this laboratory for innovation concept. It is true, each of our states is doing something very innovative, all 6 of them. And they don't necessarily share that with the other states. So we don't have a mechanism other than NASTAD, the National Association of State and Territorial AIDS Directors, where they come together, and they don't come together in that context so much to share lessons learned, but the states are where you want to intervene if you're trying to reach these national goals, because they need that kind of work. So if national viral suppression goals are to be measured, all states need to be included, even those that do not have complete surveillance reporting systems. That's the only way you're going to be able to assess how well we're doing on the national goals. And for the researchers among us, this little cascade within the cascade leading to viral suppression, there are a lot of research questions in there that have not been explored that would be very helpful in achieving the overall goals. And with that, I'm thanking HRSA. I love HRSA and I love working for HRSA. They have the longest acknowledgement requirement of any, at any rate. Thanks, HRSA. And I particularly wanted to thank the health departments in particularly New York, Virginia, Wisconsin, Louisiana, and Massachusetts. And these are our UCSF colleagues working on the project. So a big thank you.